Morning, everyone, and welcome to our inaugural session of CME Palooza Spring. I am Scott Kober, one of the CME Palooza co-producers. I am joined here by Derek Warnick. He calls himself the co-coordinator. I guess co-producer wasn't technical enough for him. So you'll be seeing a lot of us today. I apologize for those of you who will have any retinal issues at the end of the day. But we are very happy to be here. Very happy to be here with our first session of the day. Our first session of the day is entitled Bridging the Knowing and Doing Gap, Quality Improvement as a Path to Change. So before we get started, a few things. I wanted to, first of all, thank all of the sponsors of CME Palooza Spring. Our gold sponsors, Intelligent Medical Decisions Incorporated, Archimedix, excuse me. Our silver sponsors, Genentech, iMedix, MedPage Today, and our bronze sponsors, Advanced Studies in Medicine, Clinical Care Options, CME Matters, CMEology, CME Outfitters, Decision Simulation, Educational Measures, Forefront Collaborative, Global Academy for Medical Education, Highmark CE, Impact Education, Infograph Ed, Platform Q Health Education, and Vindico Medical Education. Certainly without their support, this would not be nearly as successful an event. So there are a few ways to ask questions during this session and any other session during today's CME Palooza Spring broadcast. You can use the MedPage Today text line to send in a question. The number is 267-666-0CME 0263. You can also click on the Google Plus question and answer link located at the bottom of each video. Although you will need to have a Google Plus account to ask a question. I think these days the majority of people do. And you can also tweet your question using the CME Palooza hashtag. So we'll be keeping an eye on all of those areas to kind of make sure that we're capturing the questions, and we'll be sure to ask our panelists some of the better questions that come in. So here's our speaker disclosure slide. There is not currently a CME Palooza IPO in the works, but perhaps in 2090, Derek and I will have to disclose our affiliation and our stock holdings. So I wanted to now kind of turn over to briefly introduce our panel. Our moderator is Greg Liptak. Greg is the president of Intelligent Medical Decisions Incorporated, and we are joined also by Robert Ratner. Robert is the chief scientific and medical officer at the American Diabetes Association, and Richard Jacoby, who is the director of the Jefferson University Physicians Quality Performance Improvement at Jefferson School of Population Health, and David Rhines, who is the director of Continuing Medical Education and the vice chair of surgery at Inova Health Systems. Actually, Dr. Ratner is having someone fill in for him this morning. So perhaps, Greg, you want to introduce Chris as well. So with that, I'm going to turn it over to Chris to Greg to get started.
Thanks, Scott. Thanks, Derek. Definitely appreciate the opportunity to present here. Welcome, everyone. Yes, Dr. Ratner did have a scheduling conflict, so we have one of my good friends and colleagues, Christine Pascalis, who's the director of professional education and accreditation at the American Diabetes Association. And joining Dr. Rhines, also a good friend and colleague, Tara Kaminsky, who's the RSS coordinator at Inova Health System. So we're going to jump right into things today, talking about the knowing doing gap, quality improvement as a path to change. Figure out how to do this here. So we gave some introduction. I wanted to give a little bit of a primer in quality improvement. I think that as I attend many CE meetings and the Alliance, and there's a big push really to integrate quality improvement a little bit more in what we do as an industry. So I thought that we could kind of talk a little bit about quality improvement and its origins and how it's being practiced in healthcare. And then hear from our panel. Our panel is a great cross-section of really where things are in the trenches with regard to quality improvement. You have two health systems, one located in downtown Philadelphia, Thomas Jefferson University, and then Inova Health System, which has broad coverage in the North Virginia area, serving the DC metro area. And then American Diabetes Association, who doesn't really need much of an introduction, but is a national and global advocate for improving diabetes care, quality improvement is very important to all of these organizations, and so I invited this panel for to kind of just pick their brains a little bit about what quality improvement means to them. So, what is the knowing gap, doing gap? Well, I like to use this slide. This, in fact, was not me, but I've had some similar experiences where I knew the speed limit and I sped anyway, and our medical director told me years ago when we first started doing performance and quality improvement work, when I told him about my follies on a trip home, he basically looked at me and said, "Knowledge is not behavior." He said, "You knew the speed limit, but you chose to do something else," and this is very typical in healthcare as well. And you could maybe liken this somewhat analogous maybe to the foot exam for a diabetic patient. You don't really need to educate providers that a foot exam is an important component of comprehensive diabetes care, yet sometimes it goes undone. And why does it go undone? Well, people are busy. Maybe they thought one of their colleagues or a nurse had performed the exam. There's documentation challenges. So there's any number of reasons why knowledge does not translate to behavior. And I'm going to just kind of argue a little bit today that really quality improvement is the path to converting, to traversing the knowing-doing gap. So when you think about quality and you try to define quality, it's a very broad term, and it's an aesthetic term, and it describes anything good. You can use it to say that I had a quality sleep last night or a quality cup of coffee. There's a lot of kind of humanistic values associated with the word quality. In healthcare, we can kind of use some definitions of quality given by the Institute of Medicine as related to providing safe, effective, patient-centered, timely, efficient, and equitable care. And it's a good definition. When we talk about quality improvement, we want to get a little bit more operational because this is a science. This is almost an industry in a way. It's engineering to improve quality. And so we've kind of operationalized this definition a little bit simply as quality improvement to be modifying, measuring, and monitoring clinical care processes to achieve the goals that you and your colleagues establish. And really, it's kind of determined by goal setting, locally defined aims, a focus on processes, and we'll talk about the importance of process in a minute. And it's a very data-driven exercise. You need to have monitoring in place so that you can have reliable and repeatable outcomes. You need a lot of measurement to be able to recognize that your processes are giving you the output that you desire. And you have to make changes. Quality improvement is about action. It's about making changes and measuring the impact of those changes. So when we talk about improving quality, how do we improve quality? Historically, all living beings have improved their own quality by experience. If you put your hand on a stove, that stove's hot, you're not going to do that again, hopefully, and you've improved the quality of your life simply through experiential learning. And then, thousands of years ago, we had formal education, which was designed to kind of standardize learning process. And in healthcare, that's still classic and crucial to build a foundation of knowledge necessary to practice. So medical doctor degrees, nursing degrees, PharmDs. And then, 14th century, you have craft guilds and trade guilds forming. So you'd have the armor smith and the apothecary, and this was really a way for people to learn by experience, to learn by doing, to learn within the scope of their day-to-day activities to provide a more quality product or a higher quality service. And then you have, in the Industrial Revolution, you have a lot of products being produced. Training did not scale enough to really get everyone to produce high quality work, and you have manufacturing processes that are variable and a lot of materials coming in and out. So they would set up an inspection line. You would inspect a percentage of those products to look for defects, and that's a way to ensure quality by inspection. And it's not as common this day and age because it doesn't scale well with mass production, but you probably purchased products and have seen the little sticker that says inspected by number 34. So it still does occur. And in healthcare, really, this is what we call quality assurance, using accountability measures, case review, credentialing, maintenance certification. These are all examples of quality by inspection. And really, in healthcare today, that's the majority of quality improvement. That's kind of where we're at. We're getting a little bit better. and we're getting more into quality by design, and this is really where quality improvement and improvement science focuses. In the early 1900s, a gentleman named Walter Shewhart from Bell Labs, a physicist and an engineer, really was kind of the birth of the modern improvement science approach, focusing on systems and process and reducing variation, and less of a focus on individuals and their role in output, and more of a focus on the process and the system itself. He and W. Edwards Deming really pioneered this, and a lot of people say that this actually kind of helped the Allies win World War II. A lot of these methods of statistical process control and appreciation for systems were used to increase output in manufacturing and production during World War II to meet the demand. And after World War II, Shewhart and Deming went over to Japan and helped the Japanese really establish what would soon become one of the most powerful economies on the planet, because of how they embraced this process in their manufacturing facilities and in the output of a lot of electronics and consumer electronics. And so you have this really powerful science, improvement science, that was kind of lost in the U.S. When Deming went over to Japan. In fact, only recently was Deming kind of recognized as being a crucial figure in modern industrial practice. Today, you see improvement science principles applied a lot in manufacturing and in industrial output, but not as much in healthcare. There are some health systems in the U.S. that do a great job at this, that are known for improvement by design. And these might be Kaiser Permanente, you've heard of, Geisinger Health System, Intermountain Health. Those are a few who really have adopted this culturally and wholeheartedly as a health system. And there's another area, quality research, is designed to kind of build on the evidence of what creates quality. And so I mentioned that this is a focus on process and systems. Our very instinctive approach is to say, well, let's just get the best person for this job, or let's find the best institution, and really focusing on individuals and where people were trained and how they were educated. Instead, QI really focuses on the design of the process in which humans participate, and Deming, the pioneer, has really been known to say things like 85 to 95% of quality problems are actually determined by the process, and only 5 to 15% by people. And we in the CE industry, I think, have more of a people focus. I'm glad to see that over the years there's been a great transition into more team-based education and approach and appreciation for the team, and we're definitely moving in the right direction. So when we think about improving quality, here's your normal distribution, or your bell curve or Gaussian curve. You have low performers. You could consider these some of the outliers contributing to poor performance. Sometimes the approach has been to educate or eliminate the worst performers and an individual focus. And when you do that and eliminate those from the output of a process that this curve represents, you really only shift the mean slightly to the right. So you're not really having a strong impact on outcomes. However, if you look at the positive deviants, we'll call them, those who are doing the best consistent work, and you focus on their process and their system, and you try to emulate that, you can really shift the curve to the right a lot more effectively. And that's what we're trying to do with quality improvement when we apply this to healthcare. So briefly, I just want to touch on another thing that I think can be confusing, and I've definitely seen some confusion in this at our various meetings as an industry, is we look at quality as a singular enterprise, when really there's several domains: quality assurance, quality research, and quality improvement. And I think that we really should be focusing on quality improvement, and I'll just briefly kind of talk about the differences between those three. Quality research is research. It's a study of populations. It's science to discover quality. The goal is to discover new knowledge, to discover what intervention works best. It's highly controlled, like research is. You're controlling for many variables, and you're trying to definitively say that intervention X is better than intervention Y and produces better quality. And you might say that the goal is a plan, do, study, publish type scenario. Quality assurance is an auditing process. It's studying organizations and individuals to measure quality. It's Its goal is to give you a barometer for how performance and quality is at a given organization or within an individual. And it's a reporting process, a plan, do, study, report. Quality improvement, however, is a process-driven enterprise. You're studying processes and trying to understand their output and affect their output. And it's engineering to improve quality. You're modifying these processes to have some sort of a change. And it's a plan, do, study, act. Action is the key here. And then we do want to publish the results of what we do in QI so that others can learn from it. About quality assurance and accountability measures, I often see a lot of emphasis placed on incorporating quality metrics into CE grants and proposals. And it's certainly important. It's a good way to get a barometer. It's a good way to set a baseline. But it does not inform us of how to change to achieve higher quality. So you can use this as an analogy here. You've got your feet in the fire and head in the freezer, but your temperature's just right. Your population metrics might look okay. But to really understand where to change and how to change, you have to dive into that a little bit deeper, and you have to apply improvement methodologies. So just a couple more slides. The value of QI, I think, to us as an industry is that we have a lot of resources going into knowledge acquisition. The CE industry spends almost all of our resources on knowledge acquisition. But if we invest in QI, we can have a better ability to translate this knowledge into practice. Change in action, as opposed to learning, is the objective in the intervention. It's a really key point. As educators and as an industry, we get kind of stuck on looking at our education in a silo. As our education is what's going to change outcomes. Our education is what's going to do this and do that. It's really more holistic, and if we have a more holistic approach, I think we're going to see better sustainability of our efforts. And so the classic, give a man a fish, feed him for a day, teach a man to fish, feed him for a lifetime. QI is really teaching organizations to fish. And scalability is a key issue. In CE, traditionally, we educate a large audience, and then we measure outcomes in a subset. In quality improvement, we start locally. We act with local problems, local challenges, work on improving them, and then amplify those efforts through early adopters, through individuals who are motivated to help change organizations. We actually can use even the results of that in a traditional CE setting to educate a large audience and share and amplify these efforts. And finally, it's a really great area to be in. It's challenging. It's mathematical. It's really kind of an engineering discipline. So if anyone's in the audience is interested in learning a little bit more about QI, there's a lot of different methodologies. I'm sure you've heard of Six Sigma. That's probably a little bit more applicable to manufacturing. But this is really kind of the Bible to us, if you will, this particular book. So if you're interested in learning a little bit more, by all means, this would probably be a great place to start. We're now going to jump into a discussion. So I'm going to start asking our panel some questions, and thanks for your patience while listening to me drone on, panel. So I'm going to start with a pretty broad question, just kind of talking about the national quality strategy and really how our health system as a whole has started to change and transition and to focus more on quality, and what that has meant to our panelists. So I'm actually going to start with Dr. Rich Jacoby from Jefferson and ask, how has the national quality strategy impacted the way your organization operates? And can you speak to some of the changes you've made in the past few years, strategically, structurally, to focus more on quality improvement?
Yeah, thank you, Greg. First of all, that was a great summary. And I think it really gave a good background for folks. Just to give a little sense for what goes on here at Jefferson. First of all, understanding us a little structurally, Jefferson is a 700-plus physician practice plan, plus a whole hospital system. Overall, about a $2 billion organization. And the fact is the national strategy, especially as more and more dollars, and this becomes very real very quickly, as more and more dollars are being put in to pay for performance programs, and the national direction that Medicare has put out there, where they've basically stated that by 2018 we're going to have more than 50% of reimbursements to healthcare providers being based on value rather than fee for service, you know, those institutions that really were not already engaged in, shall we say, establishing a culture of quality. And Greg, I think you put it very well. Education about quality, which is a challenge in its own right and very difficult in an organization the size of ours that has many silos, many political you know, dimensions, because yeah, we're a practice plan, but we were also an academic institution. There are many departments, you know, where the authority chain lies and all that to get things done. Greg, I think as you saw, you know, when you your group worked with us on our performance improvement project, many hoops to jump through. Very difficult to get from intellectual knowledge to actual implementation. Can't do it in a straight line. So I think it's very important to appreciate that this, again, the cultural reorganization or the education is a huge piece here, because you know, physicians in particular have so many things on their mind that they're paying attention to. Fee-for-service medicine is pretty easy to understand. Value-based payment is a model that's a huge challenge to get them to understand. And I think any of the types of programs that you're talking about, and as we had here at Jefferson, that sort of raises the awareness, that supports the cultural transformation we're trying to get to with performance improvement and quality, is all to be supported. Thank you.
Thank you, Rich. Dr. Rines, Tara, same question. Kind of how is your organization really adapted to the national quality strategy and some of the things Rich mentioned in terms of, you know, the transition to value-based payments?
You know, I think Dr. Jacoby set the stage well. My official title in surgery is Vice Chairman of Quality and Safety. 15 years ago, that never would have existed. I think that as we have seen how many resources are being thrown into quality, both at the Inova system level and at each hospital level, I think that we have had a huge change, partly driven by the federal government, but also driven by the fact that we've always assumed that we were giving quality care and no one was measuring it. We were just looking at it and not changing. And so I think that we're in a major shift of how we are approaching, how we're teaching people, and what our outcomes are, and are our outcomes really improving patient care, or are we just doing something new that doesn't really work? So at the Inova system, Tara is, we just changed her position, hopefully, to be the quality person for CME at our institution. We're right down the hall from a very large system quality group. We work with quality in each of the hospitals, and I think there's been a major shift in how we approach outcomes now, and that we're really looking at them and making sure that we're actually changing things. So I think that the national quality strategy is a huge change. That when it started, we all said, well, we're all doing quality medicine. We don't need to do this anymore. But I think we've realized that maybe there are a lot of things that we need to do better. We need to see what we're doing, excuse me, and as we're educating people, we have to educate them not just to show them what the newest and best is, but we educating them so that their patients actually do better.
Well, thank you, Dr. Rines. Christine, how about you and the American Diabetes Association? I know it's a different scenario for you because you're not in the business of providing clinical care, but you're in the business of patient advocacy, and so National Quality Strategy certainly is looking out for patients. And what's kind of your thought on how the ADA has viewed all of these kind of transformations in healthcare?
Certainly, Greg. And ADA is celebrating our 75th anniversary this year. Certainly, we have a rich history when it comes to improving the lives of patients with diabetes and all of those affected by diabetes. We have always been committed to research and professional education. As you mentioned earlier, we value the team-based approach. So as such, we are an accredited provider through the ACCME, but also to an additional 8 or so medical accrediting boards. And with that commitment to research and to professional education, the key is to translate that research to clinical practice. And especially the strategic change we've made recently is to focus on the primary care community, who are the majority of treating the patients with diabetes. We have been an accredited provider for over 30 years, and we've always been focused on achieving level 4 outcomes, as you were mentioning, which is competence. So pre-testing and post-testing evaluations has really always been a part of what we do in our department. In the last 5 to 10 years, we've probably wordsmithed more questions to gauge physician intentions and to incorporate more follow-up surveys to see if change has actually occurred. We are also evaluating our programs for consumers. So as a large nonprofit, we do focus on research and professional education, but certainly there is a large membership of consumers and patients, as well as a government and advocacy department. I think the best change that the ADA has made, and it occurred in late 2011, was that we hired 2 new positions and created a sub-department of our research department, which is fully dedicated to outcomes research. And their main focus is on outcomes measurement and strategy development and implementation for consumer programs. And more we are working in professional education with that Department of Outcomes Research. In working with IMD for the last several years now, I believe it's since 2009,
yeah.
We have always submitted grants to achieve level 4 outcomes, but now more and more we're submitting grants for programs like this that will achieve the higher levels. So that's really the strategy and structural change that we're making, even with our rich history of 75 years.
Well, thank you, Christine. Yes, and I can certainly speak to working with ADA since it has been 6 years. Wow, on performance and quality improvement programs around the country, and we're starting to really have quite an impact together, I think, in getting the mindset of healthcare systems to really change to focus on looking at these key measures in diabetes care and patient care generally.
Mm-hmm.
Dr. Ryans and Tara, I'm going to go back to you actually because you mentioned something near the end of your last comment about the integration and the partnership between your CE, CME departments and QI departments, and even being relatively located on the same floor in the same building physically, which is actually fairly unique in my experience. I work with a lot of different institutions, and the CME and CME and QI groups are typically not that well aligned. Could you speak just a little bit to how you're working together organizationally at ANOVA?
Sure. So as much as many departments work in silos, we really try and work with our quality improvement department as much as we can. Like you said and Dr. Ryan said, they are literally down the hall from us, so we can run down there and bounce ideas off of them all the time. They've been incredibly helpful in running numbers, pulling data for us to then give back to you, and identifying various areas that we might be interested in exploring in quality improvement projects. And then our senior leader is both overseeing CME and quality improvement, which also helps quite a bit.
Great, thanks, Tara. Dr. Jacoby, how about Jefferson in terms of more integration between performance, quality improvement, and professional development?
Yeah, well, Greg, I think as you know from your experience, we're again, being larger, as was mentioned, we probably even have more of the silo issues than some other folks, some other institutions do. But the good news is that I think we're clearly raising the level of awareness of the importance of these types of programs. Really, in multiple dimensions. One, because again, most importantly, we're trying to raise the level of awareness of the importance of these things. The world is changing. You know, I think classic CME has its role, to be sure. You know, particularly I think when you get into the technical aspects of things. But I think these types of programs, you know, while again it even requires a little bit of education, at least on our end of the CME department, of you know, what you know, needs IRB approval and what doesn't need IRB approval, and what we're going to do with the information. There's a lot of hoops to jump through. But long story short, I think because we you know, are first of all supporting this whole initiative. You know, we're definitely you know, trying to facilitate more and more of these types of programs, because again, you know, while it sounds like a simple operational issue in the beginning, at the end of the day, and interestingly enough, the organization is even starting to pay attention. They understand that, yeah, we're a research institution as well. Research funding is drying up through classical channels. The reimbursement system is changing. We really, if we want to maintain our what we consider to be our leadership role, we've really got to get on top of this stuff. So all the little bits that build and support it are very important.
Thanks, Rich. We're going to talk a little bit about data now, and I think that we've seen over the years in the CE industry a much greater focus on the importance of data, both in helping drive our decisions as educators in terms of which areas to focus on, but also being able to measure that our programs have an impact. And I think, given that quality improvement is such a rigorous data-driven pursuit, just kind of get some of your thoughts, and I'll start with Christine on this question. What are some of the ways that the ADA uses quality data in terms of either derived from the work that we do together, for example, or from your own external sources and other research programs that you're involved with, and registry projects and things of that nature, Christine?
Yeah, so I think that there are really an infinite number of ways that we can use this quality and data to inform CE activities. As a surveyor and as an accredited provider, I think that many providers do an excellent job at needs assessment and using data for needs assessment and proving why a certain program or a certain topic area is needed. This is usually done through a literature review or examining government or population data, but certainly the data that's extracted from these programs is more helpful. As CME providers, we strive to improve the knowledge, competence, and performance with the ultimate goal of improving patient outcomes. And I think all accredited providers do a decent job at achieving the ACCME's criterion 1 through 15. But with the ADA, we naturally achieve the criterion 16 through 22 just by nature of our association. And we try to continuously improve upon this, not only to meet the ACCME's checklist, but also to meet our strategic plan and our organizational direction. I think that the strong metrics, Greg, that are captured in programs like this and other CE programs are leveraged in about 3 ways. The first is to drive programmatic strategy, whether it's for professional education solely or for the organizational priorities at large. The second would be to determine which programs should and need to be replicated or refined in order to maximize effectiveness. And the third, quite frankly, is to increase financial or staff resources to support the high-impact activities proven through this QI process. So it really is a multimodal approach.
Well, thanks, Christina. It sounds like it's very valuable to your organization to be able to have and use this data. That's great. Dr. Ryan Zentero, same question to you. How is your organization using quality data to inform planning and development of professional development programs or CE programs?
Well, you know, one of the real problems in this, and this is a really huge change for all of us, is you need a measurable. And it used to be the measurable was the room temperature good and did you learn something? To have an actual measurable is much tougher. You know, Christine has the advantage of a hemoglobin A1C is an easy measurable. There are not lots of easy measurables in every area as we go on to, and that's why the data becomes so important. we just switched over to Epic. Not quite as data gathering friendly as I was hoping, but our outpatient data gathering will be improving. We're going to be, I think, hopefully working with you and some of the other providers on how we do with anticoagulation. But you need that data, because if you don't have measurable data, then we don't have an endpoint. We don't know what the outcome is, and just saying, did your patients do better, that's not going to help. So I think that data is really important. Tara can tell you a little bit about how we're actually gathering it.
We have been fortunate to work with our population health department, and they've been wonderful in running data for us, pulling numbers, and IMD has been great. We've kind of passed those numbers off to them, and they've been running those numbers more into our baseline data, and hopefully we'll be able to come up with some outcomes numbers in a few months.
But it's not something that the CME group can do by themselves. That's I think the important lesson is there's no way that CE or CME or professional development can be the data gatherers unless they are really aligned with population health and with their quality people.
Yeah, that's a really great point. There's so many barriers to data, and you mentioned Epic, and Health IT is certainly one of them. I think just a tidbit of info for the audience that it was really not designed as an outcomes platform. Really, all of these electronic health records were designed as a billing platform, and then kind of modified over the years to be a little bit more informative toward making good clinical decisions. But it makes it challenging, and then you have several layers of complexity, including IRB and then just the actual person. And I know I'll pass the same question on to Rich in a second, but in experience of working with many different systems, it's hard to get data, and that level of partnership and organizational awareness is very important to be able to help inform these activities. And Rich, I know at Jefferson that it's a desire to keep improving all of your groups, individual silos, and organizational departments involved in quality improvement with regard to data access. Can you speak a little bit to how you're evolving with data at Jefferson?
Yeah, sure. Well, first of all, the data part of this is huge. I mean, you can't even say how important it is, and we know the role that having good data plays in all businesses, and now it's coming to healthcare. And in this spirit of full confession here, I'll tell you, here at Jefferson, when we try to get data, and we're in the midst of it because we're trying to do some of these types of not just performance improvement, but evaluation programs that we've been charged with by our chief medical officer. When you pull back the covers, we have 26 different computer systems that feed into, well, I'm not sure what it's feeding into because we don't have an enterprise data warehouse. And the simple fact is, the good news is that Jefferson has a new president over the last year and a half. They've sort of taken a fresh look at the whole institution, and Jefferson is a fine organization, but behind the scenes, like a lot of big places, there's a lot of issues you have to deal with if you want to come live and thrive in the 21st century. So as a matter of fact, we just hired a new head of IS&T to guide this whole thing. They're looking at data from all different ways, and to Dr. Reines' point, remember in a big organization, Epic or whatever your EHR is, that's only one component. You still have to, in the way our world is organized with billing data and claims data, and how well or how poorly physicians actually document what goes into the EHR, and whether it's in discrete data fields or in text fields that are a little bit harder to mine, although there are some software tools now that let you get at some of that information. long story short, data is huge. And the other bit that you need to make any of this stuff happen, of course, is you need to have a budget to support it. Because again, we can talk about it, but you know how that works. So.
I know how it works. Yeah, we all do. Yeah. I see Scott. Is there a question?
Yeah. So there's a question. So this was posed to you, Chris, but maybe Greg, you might also want to attack this. So how do you measure learner changes in quality when you are not within a health system?
It's quite difficult. I think that as people are dependent on the ADA for information for diabetes, we're dependent on the data to tell us what information is still needed. So focusing on the level 4 competence that we do for other live programs, we do pre-testing and then post-testing 3 months later with a follow-up. The questions that we ask in regards to intentions is really physician self-report. Which is why we wanted to dive a little bit deeper in working with IMD and Thomas Jefferson and Inova to get more data to tell us what we need to do in terms of more CME and more education.
Yeah, it's a great question. It's, you know, when you're talking about measuring quality or intention to change, you know, that question that's common on CE evaluations, you know, as a result of this activity, will you go back and do some sort of practice change? And you know, most people are going to say yes. And then most people are going to go back to their practice, and the human side of change kicks in, and you're going to be up against the same barriers of time constraints, resource constraints, and you know, the best intentions are going to go by the wayside a lot of times. So if you're not in a health system, you can still probably try to measure this. Again, like Christine said, you're going to be looking at self-reported data to be able to measure what someone. So not only do you ask the question, what is your intent to change, but actually send them home with some tools. And there's a lot of interesting quality improvement tools in that guide I linked near the end of that talk. And if you go online, there's some great tools that are pretty friendly to be used in lieu of or to build on evaluations that you could then query people for what they're actually doing in practice to make changes, and that's pretty powerful stuff, even if it's self-reported. So.
Okay, great.
Okay, we're getting to about 15 minutes left. Scott, are there a lot of questions? Not really.
No, you guys can go ahead, Greg.
Okay, so we're going to probably pretty much go right up to about 9:55 or so. We'll get a couple more questions here. So one of the things I was interested in asking, and this is something that we are challenged with at IMD too, and I'll start with Christine, being the patient advocacy organization, but the CE industry is always trying to get patients more involved in our programs. Mm-hmm. And in quality improvement, one of the central tenets of good QI and implementation science is to use and leverage the foundational knowledge of people on the front lines of a process, people directly involved with the process. And in healthcare, obviously, the patient is crucial, is central to healthcare. So, Christine, how is ADA interfacing with patients to use their experience and their information and data from patients themselves to kind of inform decision making with regard to either your professional development programs or your work in quality improvement?
Yes, and I think diabetes is so unique in that it really is a self-managed disease. So healthcare professionals can guide the patient, but at the end of the day, most of their care is self-management. We do have a large component of the American Diabetes Association that concentrates on patient programs, so whether it be live programs or online components at diabetes.org that can help the patient with their management. In terms of professional education, we try to bridge a professional education program with a patient education material that already exists. So for this program that we've worked with Thomas Jefferson and will be furthering our work with Inova, we incorporate our patient education initiative, which is called Living with Type 2 Diabetes. And all of the physicians that participated in the CME were provided this Where Do I Begin patient education booklet. And this is for the physician or healthcare professional to provide the newly diagnosed patient at the point of care and to refer them to the ADA for additional resources. And the resources, once the patient enrolls in this initiative, which is free of charge, the ADA will sporadically, throughout the first year of diagnosis, send them more information. The goal is to send it piecemeal as opposed to all at once, so it doesn't overwhelm the patient. Unfortunately, utilizing patient focus groups and things of that nature to guide professional education programs, that is one of our rooms for improvement. And I think with our research programs team, we might be able to incorporate that in the future.
Thanks, Christine. Yeah, patient focus groups and some of our goals have been to even get patients on our quality improvement teams at each institution, and it's challenging because of, well, many issues, but some of the legalities of consent and some restrictions there make it challenging. But it's also challenging to structure your programs so that the patient can be a key component. Dr. Jacoby, what about Jefferson and some of your work in terms of really getting feedback from patients or working directly with patients to help improve care as a process?
Yeah, well, I think in terms of, sort of getting down in the weeds type things for diabetic programs, as Christine mentioned, yeah, most of that happens, at the practice level. I think at a higher level of reporting, I'd like to say that we've got multiple proactive outreach programs to engage patients, but the fact is we actually have a relatively limited quality department. That's the simple fact. So we can only engage a certain number of direct outreach types of programs. On the other hand, we pay a lot of attention to CG CAPS. That's a very important feedback mechanism where we get feedback from from patients in terms of how we're doing in terms of engaging them, and that's a pretty broad measuring stick as part of our involvement in the Meaningful Use program. We have a patient portal that patients can access, and that gives them the opportunity not only to check their own health records, but also some more type of let's put it in the category of wellness types initiatives that might support again them becoming, let's call it, an activated patient.
Scott, I see a question from the audience here.
Yeah, so this is kind of something we probably need to think for 5 seconds at least before you respond. So here's the question. So is high quality learning data more important than lower quality performance data, or does performance always trump learning?
Well, they're different. I definitely don't need 5 seconds. It's a good question. When you're talking about learning data, you're talking about knowledge and assessing whether or not that knowledge has been retained, if it's being used. But you're talking about knowledge. You're not talking about behavior. So they're two very different things. It's incredibly important to teach well and to assess how well you're teaching to be able to ensure that your programs are effective. But looking at performance and what's done with that is also a very different enterprise. It's impacted much more by, again, the processes and the systems of a given healthcare system. The best individuals, the smartest individuals, those who have aced this, higher, I forget how the question was phrased, but the high-level learning outcomes, and you place them in a poor system, and the effect of that system is going to trump the high-impact education any day. And anyone else want to comment on that? I'd be interested to hear your thoughts.
Let me just say that, with all the government regs on CLABSI, COTI, all the, hand washing, all that stuff, hand washing is not a great knowledge tool, but it is a really important, being used more and more as a performance outcome. You don't need to give a 2-hour lecture on how to wash hands and why it's important. That's a whole different concept than just washing your hands. And most doctors don't want to spend 2 hours learning how to wash their hands. They really like to learn about what the newest and greatest, or how to improve their practice. And so I think there's a real split between performance and knowledge when you look at something really basic like hand washing or catheter-related urinary tract infection. You don't need hours and hours on it.
Thanks, Dr. Rines.
Hey, Greg, I'd like to actually make a comment to that because it sort of plays into one of the things that you said in terms of why there is a gap. I think for the folks in the audience, it's incredibly important to understand that folks who work, I mean, teams have good news and bad news. Right? The good news is they're collaborative. The other side is that workflows and processes, if one of the ideas that you may learn somewhere that, yeah, hey, this is an outlier towards positive performance, we should incorporate that into our practice, to go from saying that to doing it and have it show up as an outcome, when you actually look, it's like when you look at a fishbone diagram, which is one of the ways we try to analyze all of the inputs into a workflow process that contribute to a particular outcome. There can be 50 little steps along the way that can keep you from getting to where you want to go as your outcome. So, obviously in a session like this, it's we're doing it at a high level, but I think it's very important for folks to realize that to move a needle is a very, very complicated process when many folks are involved, particularly in healthcare.
That's a great point, Dr. Jacoby. Thank you. And moving the needle, education and knowledge is certainly a key part of that. And we'll never, questions from the audience. I think it's an important question because a lot of people in the CE industry are looking at QI as something and asking, should we get into this? How do we get into this? Is it important that we get into this? It's really going to be, up to each individual organization. There's certainly a different skill set involved. There's a different amount of training involved. But CE and QI and professional development generally are very synergistic, and that was kind of how I think we kind of arrived here as we're nearing the end of this discussion. I did want to just kind of get everyone just to give a little bit of a closing, one quick closing tip to folks in the audience in the CE industry. What would be your advice to the audience to quickly get, one thing they could do to get more into QI or to work with an organization such as yours? Real quick, Christine.
Yeah, I think when it comes to QI or evaluation in general, I think the key is that you have to understand why the evaluation is important or why the QI is important, and to determine what the true purpose is, and also what will be done with the results. I think that is really key for CE providers to understand. I think we know what we do well, but then seeing what we do well perhaps and where our deficiencies are might be something different. In addition, I think you need to have an examination of the utility and the feasibility and the accountability of the results. So a lot of people, in my experience, internally and externally here, sometimes view evaluation as a finger pointing or as something that can hurt them personally or hurt them professionally, as opposed to what's needed to improve. So I think really examining your self-study, your ACCME self-study as a learning tool to see where you are currently now as a provider and where you want to be.
That's a good point, Christine. Thanks. Almost kind of do quality improvement on your own process when it comes to evaluation, and don't measure just for the sake of measuring, but have meaning to that measurement. How about Dr. Jacoby, just some final thoughts from you?
Well, at the highest level, all I can say is we welcome all the help we can get.
Dr. Rines, Tara, any kind of final thoughts on
just
the CE folks?
It's not an easy transition to go from what's the newest and best device to how do we improve our patient care, improve it. And you need people to buy in from below, as Christine said. They got to believe that it's worthwhile for them and their patients. And you've got to get administration. You've got to get a leader who is willing to say, we need to do more than just have a breakfast meeting and talk about one thing. We really need to follow up on it. And it's really important to have the buy-in both at the top and from the physicians at the bottom.
Thanks, Dr. Rines. Well, thanks, everyone. And my final thoughts really echo what Dr. Rines just said. For those CE professionals in the audience really interested in getting into QI, get the basics down. Like Christine said, don't measure for the sake of measuring. Your measurement needs to mean something. And get leadership buy-in from clinical systems. It's going to make your life a lot easier. You're going to have people on your team really wanting to improve. And with that leadership buy-in and a bit of understanding of data, CE professionals, I think, are well positioned to assist with QI activities. With that, we're going to end the session and turn it back over to Scott. Thank you, everyone. Thanks, Scott. Thanks, Derek, again, for the opportunity. My panel, thank you guys very much, and have a great day.
Okay, well, great, everyone. Thank you so much. And two quick housekeeping items before we wrap this up. We have a quick survey that is on the live tab of the CME Palooza Spring website. And this survey will allow us to see who's watching, where you're from, and kind of get some information to help us plan for the future. For those viewing the CME Palooza Spring Live, to view the next session, you will need to refresh the browser that you are watching this in, and we will get started here in a few minutes. So thanks again, everyone, and hopefully we'll see everyone soon.